Laboratory monitoring of a patient with polycythemia vera involves many aspects. It certainly involves monitoring the degree of erythrocytosis and monitoring specifically the hematocrit, keeping that level under 45%, whether that be through phlebotomy, whether that be with hydroxyurea, or even other cytoreductive therapies. Now, it's important to monitor the other blood counts themselves, leukocytosis, thrombocytosis. We don't want those counts to be excessively elevated, but we need to be mindful that they don't decrease to a concerning level related to excess myelosuppression from a therapy like hydroxyurea either. And that individual certainly could develop neutropenia or thrombocytopenia and have risk of infection or bleeding. We do monitor liver and kidney function. It would be uncommon for this type of intervention to have an adverse impact on either of those two organs, but important things for us to be monitoring. Now, uncontrolled polycythemia vera in the context of taking hydroxyurea really might have several different phenotypes. I view that our goals are control of symptoms, control of splenomegaly or resolution of splenomegaly, control of the counts, and absence of progression. And individuals really having breakthrough on any of those factors probably are having an inadequate response to hydroxyurea. Hydroxyurea is a helpful cytoreductive drug, but frequently is the most effective in controlling the counts with polycythemia vera. But if it disappoints us, it's usually in that context of trying to control disease symptoms, splenomegaly, or other aspects of myeloproliferation that are not as count-based as strictly erythrocytosis. This individual is now really presenting with additional symptoms. He has abdominal fullness, and on exam we find that the patient has splenomegaly. The individual is having some signs of toxicity with the hydroxyurea, with difficulties with both appetite and food really not tasting appropriately in the setting of those doses of hydroxyurea. For me, that represents both some degree really of resistance, particularly the development of splenomegaly is showing me that there is really inadequate control of the myeloproliferation in the setting of that dose of hydroxyurea. But additionally, there is a suggestion certainly of intolerance of hydroxyurea as well, based on the issues of appetite and change in taste. This individual has inadequate control of their erythrocytosis. And one can measure that in a variety of ways. Is that need for ongoing phlebotomies well into the time of therapy? Is it an increase in the hematocrit? Is it every time one checks the hematocrit for phlebotomy, their level is above 45? All of these indicators in this individual demonstrate that despite the current level of therapy, which has been fairly aggressive with recurrent phlebotomies and the need for hydroxyurea, the degree of erythrocytosis is not adequately controlled. This both helps to propagate the symptoms associated with the PV for this patient, but also it increases that risk of thrombosis or bleeding in that the patient does not have the adequate protection of control of erythrocytosis. This individual also has now leukocytosis. That is an additional risk factor that has been identified, both for risk of thrombosis and bleeding, as well as contributing to symptomatic difficulties. Indeed, as an individual who is also now found to have abdominal fullness and splenomegaly, those features of leukocytosis suggest an additional level of myeloproliferation that impacts both symptoms as well as risk of thrombosis and bleeding. And in the ideal world would be well controlled with the medical therapy selected, and the hydroxyurea at its current maximum tolerated dose is not achieving those goals.